Good morning, ladies and gentlemen. Thank you for taking out time today to listen to me. And a big thank you to the conference organizer and KLE Institute. Well done. Very good. Great job for the initiative. I'll be talking today about pain and the advances in pain sciences from Australia. And my topic is rethink pain. So it's simple as now. It was a great opportunity when I saw that invite for uh, attending the conference and doing a presentation. And it did mention some hands-on technique or some video or anything. And I was thinking, all right, there would be many people doing that. So I thought that let's have a change in the flavor. So it is an awesome conference with lots of hands-on presentation, which I've seen from yesterday, and today it's going on, and just we finished with one of them. So hands-on presentation and from the very knowledgeable and eminent clinicians. But how about let's do a brains-on rather than hands-on with me now. I hope you guys are ready for that. So sometimes they say that pain sciences is pretty dry and boring. I will accept it. But for me, it's very interesting and fascinating, which I was never taught. So that's why I want to bring that here. To be clear, it is not a pain management recipe for any condition or any cases. It's basically back to the basics about pain, which we studied in our first year and second year, and then how it progresses through life, where we specialize in this area, where people can go and specialize in this area. Pain, this is a very vast topic to be covered in just 40 minutes, so I won't be able to cover much at all. So I will be only covering why rethink pain, why we should rethink about pain, the current practice, which is the biomedical model of care. Then I'll be going into the latest biopsychosocial model of care, and then I'll be discussing some contemporary, which is the modern pain sciences. Before we start, I have a disclaimer. We always do that. A disclaimer, before you start the movie, there is a disclaimer. My disclaimer, let's hear it. As a pain revolutionary, we always start with an apology to all the clinicians present here and elsewhere listening to me in this area. I have no intention to be disrespectful to you or your current practice or your knowledge or your experience. If you felt that way, please accept my sincere apology. The session is only about raising awareness, and that's it. Thank you. Right. So you can see the difference. I remember my young days when I had a black and white telly which had Doordarshan on that, and we used to watch. And there was no remote. And there was no channels to change. So it was only the volume. You would have to stand up and switch and on and all those stuff. You have to walk. But then what's today, you can see on that, you can press off a button. You can have everything on earth you want there on that telly. Okay. So that brings a question that it is changing. It has changed. The same television has changed. Things have changed. Your mobiles have changed. Many things have changed. So why rethink pain? What's the need? Pain and physiotherapists are very closely linked, as we know that. I'm just saying musculoskeletal physiotherapist who deals in that, not the neuro or women's health. They also deal with women's health. They do deal with a lot of pelvic pain area. So that also comes in that. But anybody who deals neuro, they do with stroke patient with the shoulder pain and still pain. So pain and physiotherapists are very closely linked, and we treat pain with pain on daily basis. It's our bread and butter. Everything we do, it's to manage pain. People come, majority of them. Now, remember this thing. Pain is not only the reason patients seek care, but it is one of the most common symptoms reported to the health professionals. That's one. Pain and this pain and that pain and everything. So do we have to rethink pain? I say yes. We need to, as time has changed, so the pain sciences has advanced as well. As we know, in many areas of health, we have progressed, and that goes same as pain sciences. We have progressed there as well. When So this question is very important. Just while you listen to me, can you answer this question inside your heart, inside your mind? When was the last you studied your about pain? Not sure about you, but about me. In my first year, when I studied my anatomy and physiology, remember that spinothalamic tract? Remember that? Yes, maybe some people have forgotten, but that's, yes, I remember that. And in my second year, when I studied pain gate theory in electrotherapy, and that's it. I never studied about pain. It was all about pain management and different kinds of pain. But the basic of pain was, that's it. That's no more than that. And that is the current practice still. I studied in 1996, and now it's how things have changed, but it's not changed much. So the old anatomy and physiology books, which we still study, I agree, old is gold, but not in terms of science, which keeps advancing. It keeps changing as we find evidence with research. We need to keep updating our knowledge as well. It's the same textbooks taught in medical schools, and it's not just only in physiotherapy. It's the whole medical health professional. They read the same, they study the same anatomy and physiology, that some in depth, some in less in detail. Now, this slide, which is on your screen, this slide was raised in my recent study when I did my professional certificate in pain sciences from University of South Australia in 2019. And I said, really? So I went to the books, Gray's Anatomy book, and checked page number 75. Yes, it's right. And Snell's. And I checked the clinical neurotomy, and exactly this same it is mentioned on that. And what does it say? I just highlighted words. I'm just going to read that. The modalities carried by these nerves includes temperature, pain, and touch. All types of pain reception takes place in the free nerve ending. Pain impulses. Everywhere is pain receptors. Pain sensation ceases. The best part is there. Pain sensation ceases only after tissue damage has ended. Really? Okay. I'll back off because these books are really old. I think so. My granddad, if he was a doctor, he was one of them. He would have studied the same book I studied, and I think so my son will study the same. It's not changing much. Where are we going wrong? So, as we are talking about the books, anatomy and physiology, the historical perspective and textbook depiction of pain in my first year, what they tell about that. And this is research based, what they have come up, that they are saying the textbooks are outdated and presents theory as facts, not evidence. Yeah, I agree. Anatomy and physiology is required to understand the basis of pain. Yes, that is the fundamental basis. Senses and sensory system are not well taught. Now, excuse me, it's not about the teachers, but it's about the textbooks, not well taught. So what is the implication? So implications is clinicians may view pain as only symptoms of pathology and focuses solely on the tissues, may misinform their patients about the meaning and the source of their symptoms, unintentionally reinforce negative attitudes towards pain in their patients, might rely only on passive treatment that offers temporary pain relief but do not addresses the contributing factor, which is very important, might stigmatize patients with persistent pain who do not respond to treatment based on current biomedical model, which I will be describing you in next few slides. So Look at this slide. This comes from when I attended one of the conferences in Pine, and it was put on that. And I took a photograph, and really impressive, and really that time I was thinking, what? It's written nonsense terms. I always studied in my undergraduate days, and what are they saying? They say that pain receptors is a nonsense word, a pain pathway, pain fibers, pain message, pain. So then the second the page came, not page. They put the second one, sensible terms. So pain receptors are nociceptors. That makes sense. Pain pathway are the spinal nociceptors, nociceptive pathways, nociceptive messages, nociceptive signals, and noxious stimulus, which is the pain stimulus. And then, I can't be talking these terms to my patients. So what's the theme? So let's talk about danger detectors. Danger transmitters, danger messages, or the nerves. The danger message, potential danger stimulus. So these are the sensible and how we use, rather than, because it's not the pain's receptors. It's not. It's a receptor, not pain receptor. It's a pathway. It's not pain pathway. So modern pain science, which is the contemporary pain science, all the nonsense terms were taught to me and still being taught. Look at the old anatomy and physiology books across the medical profession, as it doesn't make any sense with the current researches. It creates more false beliefs and misconceptions among clinicals and clinicians and patients. As we keep going, you will understand it better. For example, we are still teaching our physios. I'm a physio, so I'm going to talk about a physio. We are still teaching, and it is also taught to the doctors. So I'm not surprised, but I'm focusing on physios. We are still teaching our physios that the pain is in the hip or the knee osteoarthritis is because of the worn out cartilage, the thinning of the cartilage, and the osteophytes, and the loss of joint spaces causes you pain. So you look at the x-ray, oh God, you will be in pain. Really? Is that the truth? Yes, it was taught to me. Okay. Current evidence says it's absolutely rubbish, incorrect. It's an incorrect information. It's a misconception. The science has advanced. Why are we still teaching incorrect information to our students? I bet the clinicians have not updated their current knowledge, still suggesting from the old textbook from 1960s and before, and they are still passing on that information. It's time to rethink. Now, let's talk about my second year. We have enough of first year talk. I'm not sure if you know these two people. They are the gurus. And I think so because of them, we have electrotherapy in physiotherapy world. And they are Melzek and Wall. Ronald Melzek on your left, and right is Patrick Wall. Okay. In 1965, they gave a theory called gate control theory, pain gate theory. So you know that in this is the basis of electrotherapy. Okay, let's talk about that. I'm going to talk about the limitations of that theory. It's a purely sensory model. You understand sensory and motor. It's a purely sensory model, spinal cord and nociception focused. Doesn't get to the depth of explaining chronic pain or persistent pain. It's complex pain conditions like phantom limb pain or pain in paraplegia is not explained by this theory. Doesn't account for the inflammation in the local tissue which causes pain. And the last, which is latest in the world of pain sciences, is the immune system. The role of immune system, it doesn't acknowledges it because it's latest in advanced neuroimmune system and how it affects your pains. So these all things are needed. But later, Patrick Wall continued this research because it didn't make sense to him as well later. So later, Patrick Wall did acknowledge the limitations and continued to work to understand and explain phantom limb pain. So In 1989, he developed a theory called neuromatrix theory, which was the lot improved version of pain gate theory. And that made a lot of sense. And that explained phantom limb pain. So that's him himself acknowledges they were false in that. And we are still stuck by that. We are still following that. And we are still teaching it to our students. Now, this is really interesting. I'm sorry for loading you with such a heavy word, cognitive dissonance. All right. But we have to understand that. It is easy to understand. It's a big jargon, but don't worry about that. To all my senior clinicians out there, teachers, researchers, principals, practitioners, mentors, and all of them who are there, eminent physios, please note, sometimes people hold a core belief that is very strong. When they are presented with evidence that works against that belief, the new evidence cannot be accepted. They're hard to accept. It would create a feeling that is extremely uncomfortable, which is called cognitive dissonance. And because it is so important to protect the core belief, they will rationalize that, ignore, and even deny anything that doesn't fit in their own core belief, because that was taught to them previously. And that's something really disturbing at times. If you are an experienced clinician of 10 years above, I'm not saying 10 years, I just said experienced clinician, maybe 5 years, 2 years. Let's start with that, 2 years. Anything like that might just revert to what you have done for many years, because it's comforting and for you have an anecdotal experience to prove it. Yeah, that works. So basically, let's talk about put a diathermy on the knee, or and do some static quads, and the patient gets better in 3 months. That's good. Patient gets better. So you keep practicing the same thing, or ultrasound, anything, or maybe a massage, or a ISTM, whatever, taping, dry needling, cupping, which you have learned and you are doing it and makes a difference. You are just there, and anybody says that's not right, you really take a backseat. Whoa, what are you telling me? I know that, I've learned that, and everything. That is cognitive dissonance, and people really can get very offensive by that. So sorry, defensive by that. Whoa, I don't want to be. And that's very important. I have met many clinicians who are happy what they are doing, maybe far away from evidence-based practice, but when they started the practice, it used to be evidence-based at that time. Not anymore, but they are still stuck by that. And tell you the truth, don't tell anybody, I was the same. I did exactly the same treatment for back and a knee, for a shoulder, and all those stuff. But then started realizing that I'm in a big cognitive dissonance, and then started changing. And that's what I am trying to do. Please rethink inside. As we were talking about the biomedical model, and I talked about that, I'll explain you. Let's talk about the biomedical model. So this on the right hand side is, sorry, this is a bit rude picture, but that's the picture which comes from 1600s, 1662. It's René Descartes explains. So he developed René Descartes, he developed the theory, this called the specificity theory of pain in 16th century. A French philosopher and a mathematician, René Descartes, proposed one of the original theories of pain. His theory proposed that the intensity of pain is directly related to the amount of associated tissue injury. What does that mean? I'll explain you. Don't figure out there. Meaning, a pricking one's finger with a needle would produce minimal pain, whereas cutting with a knife would cause more tissue injury and will be more painful. And people sat on that. Yep, people thought that is right, and then gradually, eventually, they developed, the further development led to the biomedical model. Now, biomedical model suggests that pain is proportional to tissue damage. So that means no damage, no pain. Remember this. I'll come back to you. So people stop moving because they think there's an injury and that's why they're hurting. So people stop moving, becomes fearful, limits healing, promotes physical and psychological dysfunctions. Really? Yes, it does. It does affect it. I'm not against it. Just don't take me there. Let me explain. A biomedical perspective is it involves search of a cause. If there is pain, there has to be a reason. Okay. Focuses on disease process. Strongly focuses on anatomical and biomechanical principle. So basically, according to them, if you get scoliosis, you should be in pain, and you cannot do much. But you know, the Paralympics, if you heard the Paralympians, they are nowhere close to perfect, and they can do things which sometimes normal people can't do. That defies that. Okay, involves more passive patient management strategies, preference curative monotherapy, like fix me please, just give me a surgery, do the surgery. A single therapy, monotherapy is a single therapy, like surgery, injection, or just do manipulation and get it fixed. That's kind of theory can foster perceived harmfulness of physical activity. Oh, if I do this, it hurts more, I shouldn't be doing it. That it means research is aimed more at cellular, molecular, and genetic levels. Poor engagement with neurosciences. It doesn't talk much with the neuroscience. May fail to recognize preventative medicine. And I think so. Today in the conference, you're going to have my school principal from University of Melbourne, Dr. Gillian Webb, and she's doing, I think so, health promotion. That's what I'm saying. May fail to recognize preventative medicine. So there are a lot of flaws in that. There's good and there are the flaws. We have to choose and select what we need. Now, now let's talk about the biopsychosocial model. What is this new word, happening word in our world? Is the biopsychosocial model was first conceptualized by George Engel in 1977, suggesting that to understand a person's medical condition, it is not simply the biological factor to consider, but also the psychological and social factor. So recognizes multiple causes from biological, psychological, social domains, strongly acknowledges the interaction between brain and body, is more health focused rather than disease focused, involved more active patient management strategies, including self-management, patient empowerment. These things are important. Involves therapies that are more rehabilitative, interdisciplinary, multidisciplinary team approach. Can alter the perception that physical activity is harmful. Can really alter it. It can change it. Research um, aimed at more psychosocial contributors with increasing engagement to neurosciences, and that's the developing part, includes psychosocial contributing factors as precursors to injury and disease. So, okay, that's all talked about, a lot of theories and da da da. So, what did physiotherapy do? Physiotherapy arena do? So, currently around the world, I wouldn't say everywhere. It's only a tiny part of the world. The physiotherapy profession is shifting, having a shift in the paradigm. So, shift in the theoretical way. It is shifting in recent years with on biopsychosocial model of care has acquired popularity in response to mounting research evidence indicating better patient outcomes when used along with traditional physiotherapy. And one of the example I will tell you, have you ever assessed a knee for a patient who has come for a shoulder pain? 99% of people who are not practicing biopsychosocial, they would say no. And I would tell that that's my practice. Shoulder pain, always I assess the lower limb because there is a contributing to that. Because let's talk about golf. Any of your sports physios are there. Just golf, the swing or the tennis. If you don't have, if you match that biomechanics there, the contributor from the leg is more important than just looking at the shoulder. That's biopsychosocial approach of care, the holistic assessment and treatment. Yeah. But one thing is always there. Just remember this. Once you have ruled out the red flags, they are, and then you go into the yellow flags, and there are a lot of flags, pink flags and all, which I'm not going to discuss here, but they are the contributors which forms the biopsychosocial. So as it says, and I say this is a slide which I have, not slide, I have a paper big laminated for my patients in the session, and I say them things that makes your daily pain worse: threat, worry, stress, anxiety, sleep, loneliness, activity level, social conflict, immune changes, negative thoughts, negative memories, sad, and all those stuff. It all adds to the bucket of pain, and your pain gets worse. Pain, remember, pain is the output. The brain tells you where it hurts. It's the output, not input. Nociception is one of the input. All the inputs are evaluated by the brain when we are talking about pain. Remember, it is either ways. Remember, a good clinician never forgets that he or she is treating a person, not the pathology. There is a huge research behind stress and how it affects pain. It is crazy, but many people don't relate that, so they don't get results. And I think so. How I started that, things were not working for me when I had done Mulligan, Maitland, Mackenzie, and all the dry needling, and this, and I would do everything, and it doesn't make sense. That frustration led me 8 9 years long in this path of pain sciences. That started making sense. Now I understand it tiny bit better. I'm still learning. Okay, let's move on. This is very important, guys. You really have to just understand, just focus it here. Okay, what we are saying, I'm saying pain and tissue damage are poorly related. Pain and tissue are poorly related. What does, I'm giving you first example. You can have pain without tissue damage. You can have pain without tissue damage. Let's talk about the story. A story is about a builder landed on a nail, huge long nail. You can see that's passing through his boot. It's not the original picture, but that's the story. And then it had a severe pain, and he was so bad, called the ambulance and took him to the hospital, and he was sedated with, I'm not sure if you understand this medication, fentanyl and midazolam. They are opioids and given post-surgery heavy drugs for pain management. And he was literally sedated, and the trauma surgeon came. They didn't have the x-ray at that minute, so they did not x-ray. So the trauma surgeon said, we cannot wait for x-ray. Let's cut the boot on. And when they removed the boot, they were surprised that even not a drop of blood had come, because the nail had passed between the toes. And this patient was up and down to push those men. And he was genuine. He was on no drugs, no alcohol, nothing. He was a genuine worker, but the pain was real. Okay, real. And this was published in British Medical Journal by Fisher et al. In 1995. If you want to Google it, search it, it is there. So you can have pain without tissue damage. Let's go to the shark story, which says tissue damage without pain. So this shark story is, this was Chris. This is Australian story in Brisbane. So this was that shark bite, and he said in the news, it didn't hurt. And he had lost literally half of the limb. The most he felt was shark's body hitting during the time. Chris was attacked by a bull shark. Australia is famous for that big, dangerous sharks. Bull sharks. Says he felt no pain despite being left with damage and torn and severed tendons and arteries, everything. It was he survived, but it was crazy. But he said, what happened there? He had fear that he want to run away from the shark. Pain was no factor for them. So you can have tissue damage without pain. Pain was not an issue. He didn't want to be eaten by the shark. So he did a runner from there. He swam to the shore where he was safe and all those stuff. Where was the pain? The purpose of pain is not to give current status of your tissue health. but to protect you. By alerting you to potential harm and motivating you to take action, pain is a protective response. Pain equals protection, not damage. Just remember that. There are a lot of evidence around that. Making Learning about pain makes sense. I'm not sure if you have seen Mick Tacker's. He writes KNOW, no pain, not NO, no, KNOW, no pain, hurt less. So basically, he's saying that knowing explaining pain, it makes a lot of sense. It says that it is a part of most commonly overlooked during when we talk and see the patients. It's a quick time. We don't give enough time to educate our patients. Pain Pain neuroscience focuses on in education and empowerment of the clients. No pain hurts less. KNOW. No pain hurts less. New learning becomes entrenched. They learn. Classic example. When we go to the doctor, what do we do? If something is hurting, can you get me an X-ray, please? I want to see scan or MRI. Just because it's not going to fix your pain, but they want to know about their pain. And that is important to understand, that why this doing an X-ray, people feel a bit better, but the pain's still there. Now, this brings to one of the most important slide. I would say that let's read this slide. It was from the same training I was in. Persisting pain is a massive problem. We know how best to prevent and treat it, but we are doing it. But we aren't doing it. We are not doing it. Best treatment and prevention makes no sense to most people. The missing link is contemporary pain education, which is the modern pain education. What's this about? So pain revolution from Professor Lorimer Moseley, a physio and a pain neuroscientist. He runs that pain revolution, and he was one of the presenters. He explained that. He says, we are sowing the seed of change in musculoskeletal non-traumatic pain for high value care to empower our patient and reduce over medicalization. And how can we do? We can teach patients. We can explain patients about how it happens and what happens, and not tell rubbish. What we say and how we say it, every bit is important to the patient when it comes to pain. Studying pain enables you to explain clearly and completely to your patients and potentially avoid making their pain worse. Mind your language. It is very important, because language is very important in health practice. What you say to the patient, what you explain to the patient. The right advice is the best pain medication. Are you giving the right advice? Just remember, that's important. If you don't know, if you don't know, it's better to leave off rather than giving a wrong advice. So this is my concluding slide, which says what? It is simply trying to say the difference from where to where we are now. So it's just an awareness session. It was just an awareness. I wanted to just tickle that something in your brain that you should start thinking. It's about the awareness session, and if you think it makes sense, then start searching for evidence, rather than just being the same. Start searching out more knowledge. Look at YouTubes and other research books, evidences. Please work on cognitive dissonance, and please contact me for further clarification if you need. But then last bit, if you think it was all nonsense, please continue your practice the same way you are practicing today and yesterday, and accept my apologies gracefully without an offense. The last bit is happy to end the session, but basically I'm saying that if you want to be involved, there are a lot of things in research, and it is there, and I'm happy to supply. Where can you find me? You can still find me. Anyone keen to get in touch and start understanding, go to Facebook and find this page, which says Shifting Paradigm and bracket Clinician's View. I'm still learning. That's what it is. Thank you, guys. Have a good day. I'm done with my slides. Sorry to bit rush, but I can see it was prompting me that you're nearly the end of the session.